HIV infection operates as a mathematically predictable biological countdown. The virus replicates by systematically exhausting a specific population of white blood cells, dictating a strict timeline of systemic decline. To understand the mechanism, we have to look at the virus's origins. The most prevalent and highly pathogenic strain, HIV-1, was introduced into the human population from chimpanzees. A second major strain, HIV-2, originated in West African sooty mangabeys. It is less pathogenic and entirely unresponsive to several modern drug classes. Despite these different zoonotic pathways, both strains share a singular operational target, CD4-positive T cells. These cells act as the primary command centers of the human immune response. The viral envelope protein GP120 initiates the breach. It docks precisely onto the CD4 receptor on the surface of the T cell, while locking into a secondary cellular co-receptor, typically CCR5 or CXCR4. Once docked, a second envelope protein, GP41, springs open. It anchors into the host cell and physically pulls the viral and cellular membranes together, fusing them and releasing the viral genome inside. Inside an untreated patient, this replication cycle produces roughly 10 billion new virions every single day. The immune system attempts to compensate, rapidly turning over its CD4 cell population to replace those destroyed by the virus. That initial binding to the CD4 receptor sets off a multi-year cascade of cellular exhaustion. The body cannot outpace the viral replication rate, leading to a progressive failure of the immune system. Immediately following that initial cellular breach, the patient enters the window period. This is a silent phase where the virus replicates massively, sometimes reaching millions of copies per milliliter of blood, but remains hidden from standard antibody tests. This timeline maps the early infection detection gap. Viral RNA first appears, detectable via nucleic acid amplification tests at 12 days post-exposure. At 16 days, the P24 antigen reaches detectable levels. Finally, the immune response lags, producing HIV antibodies around day 22. During the early epidemic, clinicians deduced the virus entirely through delayed downstream effects of late-stage disease, observing isolated symptoms without a coherent biological map. Modern diagnostics collapse that uncertainty. The standard initial screen is now the fourth-generation EIA. By testing for both the P24 antigen and HIV antibodies simultaneously, it intercepts the virus long before the antibody lag concludes. There is a critical exception to this protocol, diagnosing neonates born to HIV-positive mothers. Maternal IgG antibodies readily cross the placenta during pregnancy. Because these maternal antibodies linger, standard antibody tests are completely unreliable in infants under 18 months. Direct detection of the virus using HIV RNA PCR is mandatory. By leveraging the specific emergence times of viral RNA and core proteins, clinicians bypass the delayed immune response, establishing a diagnosis before the CD4 count registers significant damage. This graph tracks a healthy adult's immune profile, maintaining a CD4 count between 500 and 1500. Without treatment, the viral load relentlessly erodes this count. As it dips below 500, mucosal vulnerabilities like oral thrush or bacterial pneumonias appear, signaling cellular degradation. The critical threshold occurs at 200 cells per microliter. Crossing this line places the patient in CDC stage 3. Regardless of their physical symptoms, they are now legally and clinically classified as having AIDS. The loss of these CD4 cells disables the immune system's ability to coordinate a response, leaving the patient completely exposed to environmental pathogens that a healthy body would effortlessly clear. At this precise biological threshold, a ubiquitous fungus known as Pneumocystis jirovecii becomes an immediate threat. Pneumocystis causes a severe subacute pneumonia. Patients present with a dry cough, progressive hypoxia, and a notably increased alveolar arterial oxygen gradient, meaning oxygen cannot efficiently cross from the lungs into the bloodstream. A chest X-ray typically reveals a classic radiological hallmark: bilateral interstitial infiltrates radiating outward from the hyla of the lungs. To prevent this, standard medical protocol dictates a mandatory intervention at a CD4 count of 200. The patient must begin daily prophylactic dosing of the antibiotic combination TMP-SMX, which establishes a chemical shield against both pneumocystis and toxoplasma. Crossing the 200 threshold forces a shift in clinical management. physicians must prioritize the assembly of chemical defenses against opportunistic pathogens, along with viral monitoring. If the CD4 count falls below 100, the primary infectious battlefield shifts from the respiratory system to the central nervous system. Cryptococcus neoformans, an encapsulated fungus, takes advantage of this extreme immunosuppression. It is the leading infectious cause of meningitis in late-stage AIDS. It presents clinically as a subacute meningoencephalitis. A lumbar puncture is necessary, frequently revealing a dangerously elevated opening pressure due to the heavy fungal burden in the cerebrospinal fluid. Because the patient lacks the white blood cells to mount a standard inflammatory response in the spinal fluid, diagnosis relies on rapid, direct detection, visualizing the fungus with an India ink stain, or detecting cryptococcal antigen. This presentation must be quickly distinguished from another major CNS threat, the reactivation of latent Toxoplasma gondii. Toxoplasma encephalitis manifests with focal neurologic deficits, and up to 40% of patients develop seizures. Magnetic resonance imaging provides the critical distinction. An MRI of a patient with toxoplasma classically reveals multiple bilateral ring-enhancing lesions scattered throughout the brain. The clinical protocol is strict. If a patient has a CD4 count under 200, tests positive for Toxoplasma IgG antibodies, and shows these ring-enhancing lesions, physicians immediately initiate empiric treatment with sulfadiazine and pyrimethamine. Invasive procedures are delayed. A brain biopsy is only pursued if the lesions fail to shrink after 2 solid weeks of this empiric therapy. At 100 CD4 cells per microliter, overlapping brain infections share similar clinical profiles. Physicians must rely on precise antigen markers and neuroimaging patterns because diagnostic ambiguity at this stage is usually lethal. When the CD4 count falls below 50, the immune system is effectively offline. The patient's end organs are left entirely exposed to pathogens that rarely affect a functioning host. Cytomegalovirus, or CMV, aggressively targets the eyes. CMV retinitis is the most common cause of vision loss and eventual blindness in AIDS patients. It causes a painless, progressive deterioration of sight. During a fundoscopic exam, ophthalmologists look for severe perivascular hemorrhage mixed with granular white areas of retinal necrosis spreading outward. Within the brain, the 50 CD4 threshold permits the emergence of primary CNS lymphoma, an aggressive malignancy completely associated with the Epstein-Barr virus. This decision tree provides the protocol for differentiating lymphoma from toxoplasma. While toxoplasma causes multiple lesions, primary CNS lymphoma typically presents as a single ring-enhancing lesion in the white matter, requiring a PET scan or CSF EBV PCR to confirm the diagnosis. Systemically, the patient is at extreme risk of disseminated Mycobacterium avium complex, or MAC. However, modern guidelines dictate that prophylactic azithromycin is strictly indicated only if the patient's antiretroviral therapy is actively delayed. Delaying therapy points to a terrifying clinical paradox unique to this severe state of immunodeficiency, immune reconstitution inflammatory syndrome, or IRIS. If a physician rapidly restarts the patient's immune system with antiretroviral drugs while an opportunistic infection is actively present, the suddenly regenerated CD4 cells launch a massive, uncontrolled inflammatory attack on the pathogen. The resulting tissue damage can be fatal. A CD4 count below 50 represents absolute systemic vulnerability. Treatment requires carefully sequenced interventions, where even the life-saving reintroduction of the patient's own immunity must be precisely timed to avoid a paradoxical death. The downward trajectory of the CD4 cascade is not inevitably permanent. It can be fully halted and reversed through antiretroviral therapy. Modern ART is a highly targeted pharmacological architecture. Patients take a strict combination, typically 3 distinct drugs, to block different stages of the viral life cycle and prevent the virus from mutating around a single compound. The backbone of a preferred modern regimen is an integrase strand transfer inhibitor. This molecule acts by physically jamming the viral integrase enzyme, directly blocking the proviral DNA from splicing itself into the host cell's chromosome. These precise mechanisms require equally precise genetic screening. For example, before prescribing the drug abacavir, clinicians must screen the patient for the HLA-B5701 genetic marker. A positive result indicates a near-certain, potentially fatal, hypersensitivity reaction to the drug. Human genetics also point towards natural immunity. A very small percentage of the population carries a homozygous mutation known as CCR5 delta 32. These individuals naturally lack the CCR5 co-receptor on their cell surfaces. Because the virus requires both the CD4 receptor and a co-receptor to dock, the viral entry mechanism is rendered entirely useless. This genetic anomaly provided the basis for the first functional cure of HIV in a patient named Timothy Ray Brown. Treated in Berlin, he received a stem cell transplant from a donor carrying the delta 32 mutation, effectively replacing his vulnerable immune system with an immune one. While bone marrow transplants carry too high a mortality risk for widespread use, scientists reverse-engineered this exact pathway to create the entry inhibitor Maraviroc, which pharmacologically blocks the CCR5 co-receptor. Mapping the molecular architecture of the virus and host allowed medicine to shift its strategy. Clinicians moved from treating downstream opportunistic infections to engineering direct upstream blockades that keep the virus locked out of the cellular machinery. The ultimate metric of clinical success is virologic suppression. The goal of continuous antiretroviral therapy is to drive the patient's viral load down to fewer than 50 copies per milliliter of blood within 6 months of starting treatment. When the viral load drops, the half-life of circulating virions plummets. The rapid turnover stops, allowing the CD4 count to steadily regenerate by 50 to 100 cells per year, restoring the body's natural defenses. This clinical state is the foundation of U equals U, undetectable equals untransmittable. Multiple large-scale trials have proven that maintaining a suppressed viral load under 200 copies per milliliter reduces the risk of transmitting the virus through sexual contact to absolute documented zero. The final layer of population defense is pre-exposure prophylaxis, or PrEP. By administering daily oral drugs or long-acting injectables to high-risk, uninfected individuals, medicine builds a pharmacological shield before the virus ever enters the body. The biological countdown of HIV has been structurally broken. Through precise molecular targeting and strict adherence to pharmacological interception, a once fatal cellular breach has been converted into a manageable, untransmittable reality.